As you all know, Dr. Anand Moses, please. Yeah.
SR is doing the other workshop, you can start.
Yeah. So Anand Moses is known to everybody. He's a senior consultant diabetologist, emeritus professor, the Tamil Nadu MGR University, former director and HOD of Institute of Diabetology, Madras Medical College, and he's organizing secretary for RSSD in 2012, chairman for RSSD Tamil Nadu chapter now, and member of postgraduate board of studies and former member of the Senate, Tamil Nadu MGR Medical University, and EC member, National RSSDA. I welcome you, sir.
So good morning, everyone. We now move on to the plenary sessions. We have 3 interesting plenary sessions in this next program. The first plenary session is on prevention of common microvascular complications in type 2 DM, nephroprotection with novel therapies. And the speaker is Dr. Krishnan G Seshadri, and I'm not going to introduce him.
She's refused to introduce me. I feel so offended today. It's always better than saying he needs no introduction. Thank you so much. Please understand that there are conflicts of interest for this talk. I'm actually doing this talk on behalf, originally the person who was supposed to have done this talk was Dr. Jiten Vora, who was a good friend of ours. Unfortunately, he became indisposed, so you have to tolerate me. என்னம்மா பண்ற? Much of this talk is going to be speculative. If you look at it, many of the data on nephroprotection that has come out in the large CVOTs, the nephroprotection data is exploratory in nature, which means that by the time they came to nephroprotection, the studies lost their power. I don't want to get into the statistics. I think you've heard a lot about it. But remember that many of the data that we are talking about, the studies had already lost their power to comment on this, but give us an indication, because then this will spur on new interest and new theories. And that is going to be the crux of the talk. You're going to have one talk where the data is so crystal clear that Rajesh is going to speak on credence. But what I'm going to do is I'm going to spend a little time on some of these smaller things that we saw. And it took me a little while to put this talk together, but I think, the idea is, please remember this little caveat that a lot of this data, while we have done the meta-analysis, the data is exploratory in nature. Remember that there is this bi-directional relationship with diabetes and CKD. 58% of patients with type 2 diabetes also develop CKD. There's no CKD in about 42%. If it is defined as stage 3A and or the presence of albuminuria, you will notice that 8.7% have a EGFR of less than 60 millimeters. 35% have a urinary albumin creatinine ratio of greater than 30. Right? Interestingly, there is this relationship between the kidney and the heart, and again, I think Rajesh will talk about this. Dr. Mohan was very kind to let me speak on a talk of my own choosing a few years ago called the Endothelial Metabolic Axis. And it's interesting how a little concept like that, where we talked about how the endothelium affects the metabolism, is blown up now because of all these studies that are coming in showing this big link between the kidney and the heart. And this link between the kidney and the heart is developed and is driven by the changes in the endothelium. Look at this. As the EGFR decreases, the greater is the CV mortality. As the ACR increases, greater is the CV mortality. Right? This is in both diabetics as well as non-diabetics. This is Allen et al., a little older article, but look at this. As the EGFR increases, look at the standardized CV mortality. This is the adjusted HR, and the moment you go to an EGFR of less than 15, the odds ratio go up to 3.1 with an amazingly narrow confidence interval at this point of time. What is less known is this particular article from Diabetologia that showed that regression of microalbuminuria actually improves CV outcomes. Observational study, we don't have prospective data, but this seems to be something that we are seeing. That there is a link between what is happening in the renal endothelium and the cardiovascular endothelium and the outcomes. So, looks like that some of the cardiorenal syndromes and their effects are mediated by endothelial changes, and that targeting the endothelium needs to be one of the things that we do. Are the newer novel therapies, the GLP-1s and the SGLT2s, doing this? We have some preliminary animal, in vitro, that kind of data. But we don't know more, but it's time to start looking at more. But let me, in the next few minutes, give you some hints into where these things are happening. So this is looking at someone who has no kidney disease, there's a 10-year mortality rate. With albuminuria, another 17%. With impaired GFR, another 23%. The excess mortality due to both impaired GFR and albuminuria is around 47%. So the risk contribution of these two to the cumulative mortality, the 10-year total mortality, is this much. To give you an example, this is someone who has no diabetes and no kidney disease. Right. So we know that diabetic kidney disease shortens lifespan around 16 years. With early CKD, it's around 6 years. With diabetes, it's 10 years. And early diabetic kidney disease, around 16 years. The three major mechanisms. One is the hemodynamic changes that occur with this. There is, of course, activation of the neurohormonal axis. And this is the area that I keep talking too often, which is inflammation and activation of cellular immunity. So, remember that this is a multinational observational cohort study. This is 645,180 comorbidity-free type 2 diabetes. Mean follow-up of 4.3 years. And you look at the hazard ratio for cardiorenal disease. Heart failure and DKD, stroke, PAD, myocardial infarction. This is cardiovascular death. The rough things that you want to remember is that compared with patients who do not have comorbidities, if you had heart failure, the associated risk of CKD, heart failure was associated with twofold increased risk of CKD. CKD was associated with twofold increased risk of heart failure. Very interesting how they go hand in hand. This is 37,737 diagnosed type 2 diabetes patients with a mean age of 56.8 and looking at microvascular and macrovascular complications. Look at this. This is looking at early exposure, early microvascular disease, and can you see what is happening? This is the highest area of the cohort, the lowest area, but it looks like that there is a cluster that early glycemic control makes a difference in ultimate micro and macrovascular complications. That these changes, while we think is taking years to happen, their signals are starting very, very early. Remember again, I'm going out on a limb on some of these things, but it seems to be that what you do in terms of early intervention, in all of these seem to matter, and there are microvascular changes that occur very early. So among patients with newly diagnosed diabetes and 10 years of survival, HbA1c is greater than 6.5 for the first year after diagnosis were associated with worse outcomes. Immediate intensive therapy for newly diagnosed patients may be necessary to avoid irremediable long-term risk of diabetic complications. So there's sort of more and more data occurring, evidence occurring for us to say, hit early, hit hard, do more things in the first year. This is STENO2. Very interesting that, remember, this is looking at STENO2 from another perspective. We know that STENO2 is one of the most wonderful studies, small, but a paradigm of what doing different things matters. At the end of 21 years, 7 years of good control gave you 7 years of more life. This is looking at it from this thing. This is the risk of progression to proteinuria in the STENO2 trial. Remember, If you look at this carefully, this is 13.3. At the end of 13.3 years, in the intensive treatment group, there was still a residual risk. We have been talking about residual risk in macrovascular disease, not talking about residual risk in microvascular disease. And multifactorial intervention failed to eliminate the risk of new onset diabetic retinopathy in patients with nephropathy in patients with type 2 diabetes. This is a renal study, and again, you look at it, this is the primary, secondary, and other endpoints, that this was a reduction in the endpoints. But what we know is that in spite of having losartan on board, there still seems to be a residual risk. So there is need for novel therapeutic agents in this space. The question is, are the new novel therapeutic agents up to the challenge? This is looking at GLP-1 receptor agonist CVOT. In patients with established cardiovascular disease, this is leader, this is sustained, and again, you will see that there's a reduction in outcomes. The hazard ratios are very good. Remember, again, all of these are fairly exploratory. This is rewind, and again, yesterday this was spoken about, that this is looking at new macroalbuminuria. This is the renal composite, and again, you see benefit. But is there a difference between what the SGLT2 inhibitors do and the GLP-1 RA agonists do? We've seen this in the macrovascular, that the macrovascular GLP-1 RAs are slow and steady, the SGLT2s are rapid and quick. So let's see if that's what's happening. This is GLP-1 RAs looking at, this is leader trial, this is sustain, this is rewind, this is excel. In each of this, there seems to be a benefit in the renal composite. However, later renal composite, we'll talk about it. This is the meta-analysis, this is looking at the composite kidney function. This is worsening of renal function, but the overall impact seems to be that there is a benefit in terms of all the outcomes. This is, one question is, what is driving this? In the GLP-1 RAs, this is by driving a reduction in the risk of macroalbuminuria, from micro to macro. And remember, that is the low-hanging fruit, it's the easiest to do. From normo to micro is difficult, from macro to significant proteinuria is difficult, but micro to macro is a low-hanging fruit. But remember, none of these studies were sort of designed to look at this primarily. What about SGLT2 inhibitors? Rajesh is going to speak about this space, where people had established DKD, eGFR less than 60, and macroalbuminuria. What about this space where we have data, but not necessarily conclusive data? What we know is in the EMPEREG that there was benefit. There was clear benefit, again exploratory. There was no increased sign of acute kidney risk. This is the canvas, the renal composite, again there seems to be benefit. This is looking at EMPEREG and canvas and renal outcomes, and you will notice when it comes to new onset microalbuminuria, in terms of new onset macroalbuminuria, in terms of 4-point composite, in terms of the overall, and remember the ESRD, they did not have the power, you will notice that there is a shift to the left. Then, the most important thing is that irrespective of when you started, whether it was the credence, whether it was the declare, the canvas, the one thing that we know is that there's an initial decline in the GFR, and then the GFR seems to stabilize. And that's something very, very interesting, that there is a stabilization of GFR that occurs with all the SGLT2 inhibitors. So this is EMPEREG, this is persons with normoalbuminuria, this is micro, this is macro. And what you will see is that irrespective of the albuminuric status, the eGFR seems to start getting straight lined. And remember again, I've given you this caveat again and again. In many of these are exploratory analysis, these are hypothesis generating, but it's interesting to think about these for future studies. So while you don't have the dynamics of credence, you have some insight into what is going on. It's a preview for what's going to happen in the future. Now, the impact of SGLT2 inhibitors in adverse renal function seems to be greater with better renal function, as opposed to GLP-1 RAs. In the GLP-1 RAs, the worse the renal function, the better the cardiovascular outcome, at least in the leader, not in the others. But this seems to be happening. So this is declare, this is canvas, and you will see the benefit. On the other hand, the credence is an entire different ball game. I will leave it to Rajesh to speak more on that. But what you know is that it really showed that you can prevent progression of renal disease in patients with established renal disease. My talk is more about people who are early in this process. So there is an initial drop, and again, can you see in the canvas that irrespective of the DKD, there seems to be a stabilization of eGFR. Remember that these were the difference in baseline renal function, and this is the difference between canvas versus empiric. So what we know is that, at least from this, that in patients with relatively good baseline renal function, and this is using dapagliflozin, there is a slow in renal disease progression in the declatomy. Remember DAPA again, the study didn't go beyond 2 hierarchical points, so all of this is exploratory. I'm keeping on repeating these caveats. This is for us to sort of think about the future. This, and remember that again, irrespective of the baseline eGFR, there seems to be some improvement in the renal function, including the renal composite. And even more interestingly, this new concept, and we need to start doing this, the cardiorenal composite, that kidney is inherently linked to the heart, and their outcomes depend on each other, and impacting one somehow seems to impact the other. We need more and more data looking at it. We need to start re-looking at this as one big unit, and as I said in the start of my talk, endothelial function. So this showed, and I'm going to finish very quickly, that there was in this particular study in the DAPA, you had normo to micro getting better, normo to micro to macro getting better, normo to micro or micro to macro, each of this getting better. This is SGLT versus GLP-1 RI, and the one message that I want you to think about is the GLP-1 RIs work like statins and other traditional drugs. They are anti-atherosclerotic, they reduce the plaques, they work on a long-term basis. SGLT2s are metabolic. As long as they are in, they work. You take them out, they don't work, and they seem to be working much faster and much earlier. So for narrower outcomes, you will see that SGLT2s do much better. They are comparable in larger outcomes. We need more data. So I'm going to summarize where we have. What is the role of SGLT2 inhibitors today in practice? And again, must think about this. For ASCVD, where everybody kept running up and down, we know only one thing, that if you have established ASCVD, established prior MI, or MI less than 2 years, they are great. Someone with multiple risk factors, they do not provide additional benefit. For heart failure and renal dysfunction, they actually seem to do much better. And remember that heart failure and renal dysfunction are more microvascular than macrovascular. So it seems to be that there is a microvascular component that the SGLT2 inhibitors affect. Again, thank you for listening to me. This was sort of a theoretical talk. It was a hypothetical talk, but I thought I will stimulate people to thinking at the other end, because with GLP-1 RAs and SGLT2s, everybody's talking macrovascular. The microvascular piece is probably even more interesting in the next coming years. Thank you for your patience. Thank you so much.
Thank you, Dr. Krishna. We are